Good evening, all. We'll get started in just 1 minute. In just 60 seconds, we'll begin our program. Thank you for joining. In just 60 seconds, we'll begin our program. Thank you for joining. Greetings and good evening, everyone. My name is Janera Gastone. I'm first Vice President of the National Coalition of 100 Black Women Manhattan Chapter. And on behalf of our Board of Directors and members, I welcome you to our program this evening, Cancer Disparities and Multiple Myeloma. Before we get started, I do have a few housekeeping details to cover. The first is that the lines for the program will be muted for the duration of the call, and that's to preserve the event and keep it quiet in the background so we can all hear our speakers. If you'd like to ask a question during the Q&A, please be sure to put that in the chat, and we'll get to that during the Q&A time. I also want to thank our partners for this event, Memorial Sloan Kettering and the Leukemia and Lymphoma Society. We're really happy to have them with us, to have them as speakers, and we're looking forward to a great evening with very important information being shared. For those of you who've joined us for the first time this evening for this webinar, just to a little background on us, the National Coalition of 100 Black Women was incorporated 40 years ago as an advocacy organization, and our vision is that Black women and girls will live in a world where socioeconomic inequity does not exist. We advocate on behalf of Black women and girls to promote leadership development and gender equity in the areas of health, education, and economic empowerment. This chapter, the Manhattan chapter, was chartered in 1992. And so this year we are happy to celebrate our 30th anniversary. So without further ado, let's dig into the important information this evening. And I'd like to introduce our moderator for the evening, Astara Cruz, who is co-chair of our health committee. Astara.
Thank you, Janera, and good evening, everyone. I would like to start off this program by first introducing our wonderful speakers for this evening. First up is Dr. Neha Corday, who is a board-certified hematologist specializing in the treatment of multiple myeloma and other plasma cell neoplasms. She has a particular research interest in early plasma cell disorders, including monoclonal, and I hope I pronounced that right, gammopathy of unknown significance, otherwise known as MGUS, and smoldering myeloma, SMM. What a mouthful, but I'm sure we'll hear a little bit more about that later on this evening. And really just what she does is she provides a basic understanding of the disease from a biological standpoint while she is promoting other advocacy and resources. Her colleagues at Sloan Kettering would like to offer our audience a variety of treatment options. While she is practicing out of New Jersey, there is a Sloan Kettering site in New York. So we just want to make that available to everyone. And then also we would like to introduce Amy Pierre, who is a clinical director at the Flatiron Health, and she's also a nurse practitioner as well at Sloan Kettering. She received her biology degree from Tufts University in Boston. I don't want to mess that up, that's important. And a master's degree from nursing at Yale University. Ms. Pierre specializes in the care of adult oncology with a special focus to the quality of life and health behaviors in African-American breast cancer survivors. Today, she will lend her expertise as an expert hematology nurse practitioner in caring for patients with lymphoma and multiple myeloma. In her current position as the clinical director in research oncology division at Flatiron Health, She supports the development of research projects and provides clinical support for the research organization. She will be speaking to us specifically as it relates to the availability of clinical trials. And next, it is my pleasure to introduce Andrea Nagle, who is one of 2 patient and community outreach managers for the Metro New York region of LLS, Leukemia and Lymphoma Society, which also includes, just in case we have attendees from the Long Island area, as well as the 5 boroughs of New York City. I also would be remiss if I didn't make mention that LLS is located throughout the New York City area, as well as the surrounding areas. So that's Westchester County for those who might be from that area, and New Jersey. Ms. Nagle started with LLS in January of 2020 after a lengthy tenure at Habitat for Humanity, and spent time as an early interventional physical therapist and AmeriCorps volunteer. Her primary goal has always been to connect patients and caregivers that are impacted by blood cancer, and to also offer what resources LLS has to offer. So tonight we have a special treat where we'll hear firsthand of what that information and what those resources are available to us. And lastly, but definitely not least, is Ms. Nadine Sylvester, who is courageous enough to share with us her personal journey as she walks us through what her experience is like living with multiple myeloma. And for that, I thank you, Ms. Sylvester. We do appreciate your opening testimony tonight. And without further ado, I would like to get into the program and start off with she is Miss, but Dr. Corday.
Thank you so much for that introduction. Good evening. I wanted to thank the organizers for inviting me to speak tonight and highlight the cancer multiple myeloma and how the disease disproportionately affects Black patients. And I hope you find the talk informative today. Here are my disclosures. So the goals for today's talk are really to cover a few different topics on multiple myeloma and really focus on how it pertains to the health of Black patients specifically. The first is to provide a disease overview and go over the clinical presentation. Second, I will move on to how multiple myeloma is relevant to Black patients and as we discuss risk factors for the disease and epidemiology. Finally, the last portion of the talk, I will talk about multiple myeloma treatment approach and then gaps in health outcomes. So let's briefly talk about the basics of what myeloma is and where it actually stems from. Multiple myeloma is a disease that stems from a malignant or cancer-causing clonal plasma cell. What's exactly a plasma cell? So a plasma cell is a specific type of immune cell that is made in your bone marrow. And the purpose of the healthy plasma cell is to produce antibodies, otherwise known as immunoglobulins. And these immunoglobulins help the immune system to coordinate an attack when the body is fighting off infections. Under normal circumstances, these plasma cells, they live in the bone marrow cavity, and they're there in very low amounts, usually around less than 5% of your entire bone marrow, so not a lot. So now we don't know exactly what the first inciting event of why a normal healthy plasma cell turns cancerous or malignant, but we do know that it can take an accumulation of different mutations in the cells to turn these healthy plasma cells into clonal or what we call malignant myeloma cells. Myeloma disorders it's a spectrum of disease states going from different stages. It moves from a low disease state, such as MGUS or smoldering myeloma, to more symptomatic ones such as multiple myeloma, and then even more highly aggressive relapsed forms. So each stage along the way, we can see different prevalence of different mutation patterns, and that can increasingly worsen or change outcomes and then affect the disease state. It's important to realize that all multiple myeloma is always preceded by a precursor disease state, MGUS and smoldering. So not everyone that has MGUS will actually always progress to multiple myeloma, but everyone that has had multiple myeloma has had some form of MGUS before in the past. So again, multiple myeloma doesn't just happen out of nowhere or de novo or brand new. It always at least stems from MGUS. And this is a really important point because it implies that if it's caught early enough as MGUS and smoldering, at least we can track it. We do know from retrospective research data that indicates that patients that have knowledge of MGUS and smoldering myeloma disease states, they tend to have better outcomes upon their actual diagnosis of multiple myeloma if it gets to that point, compared to those patients that never knew they had MGUS or smoldering before. So how do we detect it? We detect it through simple blood tests, and your doctor doesn't routinely screen for it, like breast cancer or colon cancer. They usually have some clinical suspicion as to why they may be ordering the test. Maybe it's a kidney test that's off, or maybe you have unexplained anemia. So usually the doctor is prompted to order the actual test. What is it that they're looking for? Earlier, I told you that normal healthy plasma cells, they produce antibodies. Malignant myeloma plasma cells, they produce large quantities of abnormal antibodies, and this is called M protein or monoclonal protein. The screening test is looking to detect an excessive amount of monoclonal protein. And this monoclonal protein, it can be detected in the blood as well as in the urine. If the disease is determined to be severe enough, the doctor may need to perform a bone marrow biopsy to ascertain the level of plasma cells in the bone marrow. And this can help determine the diagnosis if it's truly MGUS, smoldering myeloma, or multiple myeloma. So it's important for the staging. The hallmark difference between MGUS and smoldering, or these precursor disease states, compared to multiple myeloma is really the evidence of the organ damage that occurs that myeloma cells are starting to inflict on the body, or the level of myeloma disease burden. It does this through a variety of different mechanisms. So for instance, the abnormal M protein that's produced by the myeloma cells, that might compromise kidney function and cause interference in nerve conduction. Sometimes patients may present with symptoms of neuropathy or sensory dysfunction. Myeloma cells can also alter the immune system in one particular direction, making patients more prone to infections, as well as cause decrease in blood counts. Patients can become anemic, they can get fatigued. And finally, the cells in the bone marrow cause an unhealthy destructive process of bone turnover, causing patients to have brittle bones, more prone to fractures, and x-rays can often show these lytic lesions where the bones are being thinned out. All this bone destruction can also cause patients to have high calcium levels, which can lead to altered mental status and sometimes constipation issues. So usually by the time patients come to see us for their multiple myeloma diagnosis, they have some sort of symptoms that are tipping us off, and their quality of life can be really affected by it. Moving on to the next topic, what I want to really dig into is really a little bit about the epidemiology and what we know about risk factors for this disease. Myeloma is the second most common hematologic malignancy in the United States overall, after non-Hodgkin's lymphoma, and it accounts for 2% of all cancers, with an incidence affecting roughly over 30,000 people annually in the US. However, among Black patients, multiple myeloma is the most common hematologic malignancy, and we're going to explore why that might be the case. There are a number of different risk factors that we've identified for MGUS and myeloma disorders. They include older age, gender, certain environmental exposures. So for instance, in Manhattan, post 9/11 first responders have a higher increased incidence of MGUS and multiple myeloma compared to the normal healthy population. We know even Vietnam War veterans that served in the military that were exposed to Agent Orange, those patients have a higher incidence. Importantly, what we're finding is that there's a genetic component to this first-degree relatives that have been affected by multiple myeloma have a higher risk of developing a plasma cell neoplasm compared to the general population. And it's possible that this familial genetic component may give us a clue as to why we see that there's a higher risk 2 to 3-fold in Black patients compared to other racial groups, suggesting that there may be some sort of ancestral or genetic predisposition link. Scientists are doing studies right now as we speak, going over and trying to figure out why this may be the case. They've done some early analysis looking at just mutation patterns in the multiple myeloma patient population of African ancestry and compared to European ancestry. There does seem to be some few key mutation pattern differences that we're finding. Multiple myeloma patients of African ancestry have a higher mutation load of certain non-hyperdiploid IgH translocations, including translocation 1114. This one in particular is kind of important in the multiple myeloma field because patients that have translocation 1114, from what we understand, signify a more chronic indolent disease course rather than an aggressive one. And even more recently, studies are showing that this particular mutation might be actually uniquely susceptible to certain therapies and targeted agents, making that this type of mutation something that we can actually address in terms of treatment outcomes in the clinic. On the flip side, we are seeing that other translocations like translocation 1416 and 1420, they tend to be more aggressive clinically. And this might explain again, for instance, why we see a younger median age of onset in Black patients. Digging a bit deeper and going into the genome a little bit, they've done some genome-wide association studies using more of a comprehensive approach, demonstrating that actually when you really look into it so far, there doesn't seem to be so much of a difference. There's actually a big overlap between genetic components of myeloma patients of African and European ancestry. The same 23 common loci are involved in both cohorts. This suggests that the biological reason for why Black patients have higher rates of multiple myeloma still remains a mystery. More comprehensive research is going on, and we're at MSK, we're actually looking at this, participating in a trial across multiple institutes. We're looking at different genetic variables across polyethnicities, trying to figure some of this out. Switching gears, I wanted to talk a little bit about treatment approach and where we are in the field today for multiple myeloma, and then digging a little bit deeper in some outcome disparities. The approach to treating multiple myeloma is a multidisciplinary approach. It really requires efforts on everyone's part to ensure a total 360-degree approach to optimizing care. It begins and ends with knowledge. Multiple myeloma is consistently and still considered incurable, but it is very, very treatable. And as research progresses, there is a hope that we're going to find a cure one day. However, when you look at how to best approach treatment right now, there are some key areas that should be addressed. Number one, patient advocacy. We also should find a myeloma expert who can basically help guide care for the patient. Finding state-of-the-art diagnostics is also important to make sure that a patient gets the best care possible. And finally, talking through all these different treatment options with your doctor and your care team, and considering clinical treatment trials if they are appropriate for you. Science and clinical research is really driving process. And over the last 2 decades, we are seeing that these novel therapies being developed are pushing the response rates to unprecedented levels. In some cases, the therapies are pushing over to 100% overall response rate, and even actually the disease can be suppressed to undetectable, what we call minimal residual disease negative levels, which means that the disease is essentially undetectable. So patients are getting these very good clinical remissions, even though it's not curable, it doesn't always last. It's important to recognize that where we are today in the field is much better than where we were several decades ago. Part of this that's driving this are really the diagnostics. Diagnostics are improving alongside of the therapies, and technology has increased our sensitivity of detection. We have developed special techniques to detect these monoclonal proteins at really low levels. This is what we would call mass spectrometry, as well as highly specialized methods of detecting multiple myeloma specific bone lesions. This is really pushing the innovation forward. And all of this, what we are seeing is actually translating with better therapeutics and better diagnostics. Multiple myeloma survival is improving. We are making a dent. So again, even though it's not curable, we really truly are impacting outcomes. This graph is from the USCR data showing that multiple myeloma patients are indeed living longer compared to just a couple decades prior. Despite this, when we dig a bit deeper, we find that mortality among specifically Black patients in multiple myeloma is 2 to 3 higher compared to other races and ethnicities. And some of this may be due to non-modifiable disease characteristics, but that's not just the full story. So when we look a little bit deeper, we see that there's a disparity in disease presentation among Black myeloma patients. Black myeloma patients, they tend to present at younger ages with higher disease burden states. And what's also interesting and striking is that the all-cause mortality is high in Black myeloma patients, but the multiple myeloma specific mortality is lower compared to other races. So what does that mean exactly? It means that Black multiple myeloma patients are not necessarily dying from their disease. It's possible that they're more affected by comorbidities like diabetes, cardiovascular disease, kidney disease. It's these chronic conditions that add up. And so that's really important. That kind of points to the access of care and how to best really manage a patient. So what about access? Looking a little bit deeper, we see that Black and Hispanic multiple myeloma patients have a delay in initiation of care, at least in the past decades. There has been some research that's showing that these gaps are decreasing. However, we still see that there is this gap, at least for access to care. And this delay in therapy initiation may be one of the reasons why we see this disparity in outcomes, especially at the presentation of disease. In fact, once patients are diagnosed, what about how are they treated? So therapy patterns can actually be different. In this study, they were looking at oral therapy versus IV injection therapy. And what they found was that 31% of Black myeloma patients were found to have underutilized intravenous and injection chemotherapy compared to other races. And IV injections need to be given at highly specialized treatment centers. No such disparity exists with oral chemotherapy. So what is it here that's going on? Is it a lack of access to care? Is it logistics, location to treatment care? Is it that patients need to work and it's more convenient just to take their oral pills, but they can't really get the IV injections that they really need? And this is really important because this impacts outcomes. So this actually is a bright spot when you look at it, and this study has come out of the Connect registry database, which is a US database. This shows that once treatment is initiated and appropriate care is found, that actually Black myeloma patients might do better. So this graphic is specifically looking at this Connect registry database. They found that once transplant, autologous stem cell transplant, is incorporated into treatment, into the treatment algorithms, we see that Black patients, actually their expected survival outcomes are higher compared to other races. So maybe once we get past some access and overcome some of the therapy initiation issues and really get the patients the care that they need and deserve and really need, that the outcomes, the clinical outcomes can be better in this patient population. So some key take-home points, and my colleague and friend, Amy, she's gonna talk a little bit and pick up right after I'm done here. But What we do know about the disease is multiple myeloma is a cancer of the plasma cell. It affects all different organ systems, and patients can really come to our clinic when they're first diagnosed, feeling really sick. What we do know is that there does seem to be a higher prevalence among Black myeloma patients compared to other races. There's no definitive explanation for why this is. People are looking into genetic and mutational causes. We're not really still quite certain why. There does seem to be a family history component to it. We know that even just upon disease presentation in Black myeloma patients, they tend to present at a younger age, higher disease burden. And we also know is that delay in treatment and access to care can greatly impact survival. Mortality rates are improving, however, over the last few years. We still need to address these issues, though. And once we see that patients actually do get the appropriate care, it might actually, there's some suggestion in the literature that survival outcomes are actually better in Black myeloma patients compared to other groups. So we need to really figure out how to make this happen. I really want to thank everybody for their attention. And with that, I'd like to hand it off to my friend and colleague, Amy Pierre.
Thank you so much, Dr. Corday. That was incredibly informative and a great way to sort of set the groundwork for what I'm going to talk about today, and outlining really what myeloma is and what we need to know if any of our family members or we ever develop multiple myeloma. So I'm going to talk to you a little bit about the importance of access and also clinical trials in multiple myeloma. And I'm so fortunate to have the opportunity to talk to you all about this really important topic today. And we can dive right in. I always like to start with sort of the most important facts you need to know about multiple myeloma. So myeloma is one of the malignancies or cancers that have the biggest sort of disparity and prevalence for Black Americans. As Dr. Corday pointed out, myeloma is 2 to 3 times more common in Blacks than whites. And the reason why that is not entirely sure, but we do know there's some sort of ancestral component to that. It supersedes non-Hodgkin's lymphoma, which is the #1 kind of blood cancer in other groups. It's #1 for Black Americans. And like Dr. Corday talked about, there are some sort of biological differences in myeloma in Black Americans that may predispose to sort of lower risk disease, meaning that there's some chromosomal abnormalities in myeloma that's indicative of aggressive disease in other groups, but less for Blacks. And the way you know that is sort of looking at the molecular of genetics of the myeloma, not necessarily the genetics that you pass down to family members. We also know that Black Americans are less likely to receive life-extending therapies like Dr. Corday talked about. So the standard of care is really 3 drug combinations. We see that that's not the case for Black Americans. They're less likely to receive novel therapeutics, such as stem cell transplantation or novel drugs in general, and less likely to participate in clinical trials. But as Dr. Corday pointed out, and what I'm also going to elucidate is that Black Americans can achieve equal or better outcomes when they actually receive optimum therapy. And the best way to receive optimum therapy is to understand what all your options are and really participate in a proactive conversation with your healthcare team that we call shared decision making. Sorry, my computer's running a little bit slow, I apologize. So I want to start off by showing some information that explains that the standard of care for Black Americans can lead to similar outcomes as white patients. So we do know that there are studies out there that have been published in the literature that despite Black Americans receiving sort of a delay in transplant after diagnosis, their overall survival is similar compared to whites. And then there was a study in the veteran population that demonstrated that those patients who were a little bit younger, so under the age of 65, we did see that their survival outcomes for Black patients were superior to white patients. So really, what are we trying to say here? That even though when there's a delay of referrals for stem cell transplants, we did see that sort of the outcomes were quite comparable compared to whites for Black patients, and that it can be even slightly longer compared to white patients from the time of diagnosis. Now, I want to talk a little bit about clinical trials, and clinical trials can really afford patients the opportunity to receive what we call really novel therapeutics that can be promising and sometimes even superior to the current standard of care. And there's a lot of misconceptions about clinical trials, and it's really important that we discuss what they are and how they're important to all patients, not just myeloma patients. So what are clinical trials? So clinical trials are a research study that compares really the most effective known treatment for a specific type or stage of cancer with a new approach. And many don't know this, but there's actually various steps to clinical trials known as phases. And we're going to go through each one. So you have a clearer understanding about sort of the natural scientific progression of these phases of a clinical trial. So a phase 1 study is a study designed to find the highest dose of a new treatment that be given safely without causing severe side effects. And so these trials have really small numbers of patients in them, and the endpoint of the trial is really about safety and tolerability. And a phase 1 study is usually the first time that this novel approach is appearing in humans after preclinical testing. And now after the safety and tolerability has been proven in a phase 1 trial, we now move on to a phase 2 trial in which the new therapy is then tested in a variety of ways to see if it works in a particular type of cancer. And in phase 3 is when we take this novel approach and compare it right up against the standard of care to see how the safety and effectiveness of the new treatment stacks up against standard of care. And then phase 4 is what we call post-marketing surveillance. The new treatment is now approved, but we continue to monitor after the approval for any sort of new safety signals. So what are the challenges that we see in the enrollment of clinical trials? All those therapies that patients get at some point continue to be a part of randomized controlled trials, which we know is crucial in drug development and for oncology patients. But despite these advantages, we know that there's a lot of barriers to clinical trial enrollment because only about 5% of the oncology population participates in clinical trials. And we know of that 5%, patients of color make a fraction of that amount. I can tell you about like 1 in 10 of myeloma patients participate in clinical trials. So you can imagine if we whittle it down to patients of color, how tiny that number is. So we know that the barriers to trial participation is really multifactorial. So this includes financial toxicities, such as the cost of missed work and attending sometimes these frequent and mandatory appointments that trials offer, lack of resources for patients and availability of trials where they're being treated. The majority of trials patients in this country are treated in the community setting, and that can have a lot of limited availability of clinical trials. So there may not be trial resources available that's appropriate for that patient's language or their culture or their health literacy. And there could be even some logistical concerns, such as difficulty in attending appointments, having transportation issues, lack of support. And we know that lack of community engagement and sort of lack of cultural competence and cultural humility can play a huge factor in patients of color participating in clinical trials. We know that there's many myths and fears and mistrusts about clinical trials, particularly of people of color who've been unfortunately, historically marginalized by the medical community in this country in the past. But that long-lasting mistrust can be a barrier to trial enrollment. And that's a real thing that we have to consider as clinicians. And clinical trials have strict inclusion criteria. The fittest patients with minimal health issues get into clinical trials, but isn't like your run-of-the-mill average patient. And as Dr. Courtney pointed out, we know that patients of color tend to have a lot more comorbidities or health issues that render them ineligible for trial participation. And we know our doctors can really be pressed for time. And it takes time and often multiple visits to consent a patient for a clinical trial, as well as lots of resources, trial coordinators, research nurses, et cetera. And the minimal multi-ethnic staff available for clinical trial staff can also affect enrollment and retention of Black patients. There was actually a study that had about 41 clinical trials in it, and a third of those trials actually failed to meet at least 75% of their planned target enrollment. So we need patients in clinical trials to further improve oncology care. And on the right side of the slide, you can see that 84% of trial participations are white, despite minorities making up 40% of the US population. There are clearly not appropriate representation in clinical trials because we can see that it's in the single digits. So we need to ensure that there's diversity in clinical trials because we know that lack of diversity in clinical trials can really limit the general findings of that trial. So let's talk a little bit about some results that came out of this study. So Prime is actually an education company that really creates and disseminates research and evidence-based findings in healthcare. And they did a study where they surveyed both providers and patients. And in the first part, they surveyed providers, you can see on the left side of the screen, and asked 2 questions. They wanted to know how often they discussed the possibility of clinical trial enrollment with their patients, and how often they referred patients to clinical trials. And you can see that there's a variability, but the take-home message is that many say that they discuss clinical trials often with their patients, but when they refer patients to clinical trials, it's a little bit less. It's a little bit skewed to be a little bit more often and less likely to be, always. Even though we're always taught as clinicians to refer a patient for a trial pretty much at every decision point in their care. And when we surveyed patients, we asked them what their experience was with clinical trial enrollment for myeloma. And you can see a variety of differences across race. When they asked, if my doctor asked me about clinical trials, you can see that actually it's commonly discussed for Black and Latinx patients, more so than white patients. But when you ask, who's referred to trials, that gap closes between the races. You still see more for Black and Latinx patients who actually enroll in the clinical trial. It's actually more white patients. And those who say they have no experience at all with clinical trials is actually more white patients than patients of color. But this tells me that we are doing a pretty good job of maybe discussing clinical trials with our patients of color, and we refer them for clinical trials, but we just don't enroll patients of color as often as we do white patients. Now, how do we overcome some of these barriers to enrollment in clinical trials? Well, we have to focus really on 6 areas, including financial issues, resources, logistic issues, community engagement, examining eligibility criteria, and providing clinical support. So for financial, we need to be completely clear and transparent about the potential of financial toxicity that patients can really experience. And we need to work hard on alleviating some of that financial stress by finding appropriate resources and funding for patients. And we need to provide trial information to all patients who are potentially eligible and make sure it's really appropriate for that individual patient to comprehend. And we really need to reduce the logistical burden on patients because frequent clinical trial visits can really be cumbersome and it can be a hindrance in participating in clinical trials. And one really important aspect of improving trial participation is direct engagement with a diverse community and advocacy groups, and such as a coalition like this. We have to really meet patients where they are. It's critical to build trust and provide the best information and education for patients so they can be knowledgeable about clinical trials. We have to engage in cultural competency and cultural humility to improve engagement in our racially and ethnically diverse groups to better understand their community. We need to work on eligibility criteria that can go hand in hand with understanding different cultures and being engaged in the community, and provide materials that are really appropriate to highlight how all patients can be appropriate for trials and candidates for clinical trials. In addition to really directly engaging with communities, we need to have really culturally appropriate education materials and more diversity in our clinical trial staff. That can really improve trust and relatability for our patients of color. So I want to just draw attention to Spark Cures. This is a website, and they help patients who have myeloma find and understand and really connect with clinical trial options at centers all across the United States. You actually can create your own account to obtain a personalized clinical trial report. So this really dramatically lowers the difficulty in finding and even understanding clinical trial options that could be potentially tailored for you. Now, Spark Cures is a great way to obtain access to clinical trials, but what about access to standard of care? So a lot of what I spoke about for trial participation applies, but I want to talk about sort of standard of care access, and how you get access is really understanding what your options are. And the only way you can truly know what your options are is to have shared decision-making with your healthcare team. So what is shared decision-making? There's really 3 parts to it. The first part is introducing choice. It's us giving the patient permission to participate in decision-making, allows our patients to be an active participant in their care. And so when discussing choices, we have to make sure that as providers, we're assessing our patients' reaction and comprehension of the choices presented. Then we got to dig deeper and, thoroughly describe the options, because there's a good chance that our patients may have already done their own research on their own, attending lectures like this, and may have some ideas about therapies we recommended and also clinical trials. So it's important to assess, what our patient's level of understanding is, to make sure we can correct any sort of misgivings that maybe Dr. Google has provided for patients. And we need to make sure there's really decision aids, decision-making tools that are culturally appropriate, thoroughly explain the risks and benefits of each care plan to make sure the patient and whoever else is present with the patient for decision-making can really explain back to us as a clinician what we've talked about. And lastly, we as clinicians really need to help guide you as a patient in making decisions by focusing really what your preferences are, and then agree to what plan. It's really important for you to know that this process isn't static. It's not one time. Revisiting your treatment plan can happen at any course during your treatment journey. I want to talk a little bit about this poll on shared decision-making as well, because, shared decision-making sounds perfect, right? The best way to communicate with patients, right? Why aren't we doing that? What prevents us from doing optimal shared decision-making? So we ask patients what they feel keeps them from being involved in active participants in their care. And we do see, again, a difference in racial groups, right? We see Black and Latinx patients stating that they really rely on their care team to make the best decisions for them. And secondly, they're just way too worried and overwhelmed to make a decision. White patients say the biggest barrier to being involved in shared decision-making is that they don't have a barrier. They feel completely involved in their shared decision-making, followed by trust in their care team to make decisions for them. So this really tells me that our patients of color really rely on us to make decisions for them, because they're too overwhelmed to participate in the care and have this dynamic conversation. So we as providers, we have to open the door. We have to let our patients know that we want them to be a part of this decision-making and give them permission to do so, and address these feelings of being overwhelmed and taking the time to answer all your questions and all your concerns and bridge that gap in understanding. But when we poll providers to find out what's happening here, providers are saying, we don't feel like we have enough time to do this type of shared decision-making care. And we also feel blocked by our perception of our patients' sort of health literacy rate. So we really need to provide the time to make optimal care for our patients. We're all doing our best, but we know that there's areas that we as clinicians can improve upon to make optimal care for our myeloma patients. There is a significant portion of the United States population that has a limited health literacy, and this disproportionately affects our vulnerable populations. When we polled patients to understand what could be improved in their myeloma care the most, there was again a discrepancy in responses between racial groups. So a third of our Black and Latinx patients stated that they wanted better education about myeloma and treatment options, followed by empathy and emotional care and counseling and sharing of realistic expectations of prognosis. White patients stated that the aspect of their care could be improved was really a realistic expectations and prognosis and even financial counseling. I mean, to me, what a difference, right, between racial groups. This tells me again that patients of color need our time. They need more education about their plan of care, and they need our empathy. I really believe this is something that clinicians can work on to really improve the experience of our vulnerable patient populations. So there's really many facets to providing culturally competent care and shared decision-making. And these things that I want you to make sure of that your clinician or your provider is doing. If they're not advocating for these key components of shared decision-making, you need to have a conversation with them, and that's what you're looking for. to be an active participant in your care and have a dynamic conversation. Your clinician should be first and foremost building trust and rapport with you. They need to be inviting questions. They need to learn who you are as a patient. They need to continuously check in on your understanding and your comprehension. Your provider needs to ask you how you best learn and take in information. They need to ask how they would like you to participate in decision-making. What's important to you? Who else should be involved in decision-making? We all have family members who are key stakeholders that need to weigh in our plan and our care, and they need to always be transparent with you. Your clinician should be avoiding judgment. They should not be defensive when you're talking about this type of conversations with them. And they should be continuing to explore your preferences as a patient and ask what they can do to support you and your loved ones during this treatment journey. So I know that Dr. Corday and I really provide a lot of information for you today, but the key home points that I'd like to talk about, some pearls of wisdom in providing optimal care and access, is to make sure you as a patient are always on the same page as your clinician. Because if we demonstrated, there's clear discordance between sort of perceived challenges and barriers and treatment goals between providers and patients. So we need to remember conversations about care and access should be encouraging patients to be active participants. And we need to learn our patients' preferences, what their goals are. And you know, it's really fortunate, like Dr. Corday talked about, myeloma is very treatable, and there's a variety of treatment options for our myeloma patients, but every single patient's different. So we need to make sure that your care is individualized and that your provider is providing the most tailored treatment plan for you, a plan that fits your preferences and your goals and your characteristics of your disease. Thank you so much for listening. I will turn it over to our next speaker.
Okay. Well, actually, we are going to take just a moment to take maybe one or two questions. It looks like we're on time, so if we could take two questions, maybe. For those of you who'd like to ask a question, oh, we've got Adina. Adina, maybe we can unmute Adina. Yeah, we go.
No. I said thumbs up. We're on time.
Oh, okay. Thank you. Adina's our timekeeper. Ronzetta, I don't know if there are any questions in the chat. For those of you who would like to ask a question, please be sure to type it in the chat and we can ask it. You could also, there's enough of us on. I think we can also unmute you if you have a question. So if you want to raise your hand, I think we can see that. Ronzetta?
So one question that's not in the chat, but that I do have for Dr. Corday is what advice would you give to a patient facing a cancer diagnosis?
Yeah, thank you for that question. You know, I think Amy touched on a lot of points, but one of the things that I would say is that seek expertise care in whatever cancer diagnosis that you are facing. I mean, today we're talking about multiple myeloma, but this could be breast cancer, colon cancer, and I think one of the things is don't feel bad about hurting your current oncologist's feelings about getting second opinions. Do as many second opinions as you need in order to feel comfortable with your treatment care plan. Explore all possible outcomes, explore all treatment options, and make sure that when you go from opinion to opinion, or if you consult with 2 or 3 doctors, that it sounds right? I mean, the treatment care plan should be somewhat consistent across the different specialists. But I would say, even if you are, you can't necessarily get to a specialized place like Memorial Sloan Kettering, but try to really get to that disease expert. And that disease expert doesn't necessarily has to be the person giving you the chemotherapy, but maybe that disease expert has to say, you know what your local doctor is doing is correct. And I do recommend that. And I don't recommend any differences, or that's a good way to go, and come back and see me if something doesn't work out. Always leave that door open. So I would say really seek that specialized care opinion if you can.
And I actually have a question for Amy. Sorry, Ronzetta, I just wanted to get in really quickly. Dr. Corday mentioned that there may be this genetic component to multiple myeloma. And Amy, you made the really great point that, of health literacy in our community, being a challenge for us, right? So, I'd like to kind of pull those two ideas together to say, and health literacy, I want to say, there are two parts to the question. One is the health literacy, is that, does that correspond to, education level? Because, I don't know. I mean, just because you're, you could be a lawyer or a doctor and still have a low health literacy. It's just kind of, to me, one thing that lacks in our community, in many communities, in many families, is that they don't share health information, right? They don't share their history of, and maybe they don't know, right? But, an auntie here or an uncle there, they don't necessarily share, what happened, because we don't talk about those things, right? So I'm curious what your thoughts are about. Looks like you're nodding, so I'm just curious from both of you, maybe.
You said that beautifully. I think, in our community, we don't talk about health issues. We don't talk about cancer. We don't talk about that uncle who had cancer or the specific subtype. You ever find out exactly what type of cancer is? Nobody knows. Right. But Uncle so-and-so had cancer. I'm not sure what kind it was. So there is this sort of missing gap in sort of, family history, right? And in terms of what you're talking about for health literacy, it really is multiple components. So it's not just health education, it's also language. So there's people where English is not their first language. And, English is actually not really the dominant language in many parts of our country. And so we really need to make sure that when we're talking to our patients about their options, that we're speaking to them in a way that they truly understand based on not just education level, but their language and how they prefer to learn. Some patients, they don't want all those statistics. They don't want to hear that. They just want to hear sort of exactly the treatment options. And if I was your daughter, or if I was your sister, how would you treat me? That's what patients want to hear, right? Sometimes they don't want to be bogged down by statistics. They want you to treat them as though they were your family member. So I think health literacy, it has many components to it. And I think as a community of color, we can do a little bit better about giving permission for us to talk about illness and to talk about cancer. Oh, you're muted.
I was saying to Dr. Cordy if she had anything to add, otherwise we'll move to the next speaker.
No, I think, I think overall, we sort of touched on some of these salient points. The one thing I would say from a provider standpoint, and really digging into Amy's presentation, is what's striking to me is on the provider side, we think we're doing a good job of giving the information to our patients, but perhaps we're really not. Perhaps we really need to do a better job of engaging and really meeting every patient as soon as they walk in through that door of what is it that you need from us, and every patient is not the same. Literally, certain patients have certain preferences and they have different life things going on that are important to them. So I think as providers, we really need to do a better job of that. So I actually have to, again, thank Amy for that wonderful presentation, because I've learned a lot from just those surveys of what we are or not doing, or what we think we're doing, but we're really not doing.
That's terrific. Thank you for that. That's and then thank you so much to both of you for that wonderful breadth and depth of knowledge, and you've really enlightened us all, I think, on some real key opportunities and challenges for us, especially the coalition in terms of the education we do. I'd like to move on to Ms. Sylvester now. We're really excited to have you here, Ms. Sylvester, to share your experience. And I'm sure, from both the clinical perspective and the personal perspective, I'm sure a lot of that top stuff really resonated. So just give you a little time for you to talk about your experience. Thank you.
Well, good evening. Thank you, Dr. Corday. She is my doctor, so I'm very blessed to be working with her. She has been my doctor since 2014 when I walked in with MGUS. So how I got diagnosed with MGUS, as she said, it's not routine screening when you go into your primary care doctor. I went in, I kept having the same symptoms, very tired, could not keep up. I had to be getting vitamin B shots. We couldn't figure out why my vitamin D was not going up. I was taking vitamin D, the highest dose possible on a weekly basis, but it wasn't making a change. And so things were not changing over the 6 months. So my doctor, my primary care doctor at that time decided to run other tests. And it was at that time she found that I had an M spike. And I was referred to an oncologist. And at the oncologist, we started to do like iron infusions, and still I was still having the same issue. And so unlike many, I'm from a West Indian background. I just turned 43 weeks ago. And my West Indian family does not talk about health issues. So when I told my sister, who works in Memorial Sloan Kettering, she's like, you really should come and get a second opinion. And so I was introduced to the multiple myeloma team, and where I met Dr. Corday. My MGUS was at a place that it moved from MGUS to smoldering in a short period of time. And at that time, Dr. Corday had a conversation with me about clinical trials. I was very apprehensive about doing this clinical trial. However, I am a trained social worker and felt like, hey, this will help. I have 3 children to live for, and why not try? So I tried a clinical trial of daratumumab, also known as DARA. I will tell you that DARA was a very difficult clinical trial. You start going 2 days a week, 8 hours a day for infusion. You are sitting in a chair for 8 hours. Then it goes down to every other week, then 1 month, 1 week. So 1 week, every other week, and then on a monthly basis. It was very difficult. You have to have a lot of financial support. Like I had a job where I could take medical leave for some of the time and still get paid. I also had a job that I can work from the hospital. So there are private rooms at Memorial Sloan Kettering. So I'd be hooked up to an infusion. I got this nice artwork behind me, and I have video calls throughout the day. I would order food to the chair. Now they're in the Coke Center. They didn't have that before. You can order right down from the cafe, but I would be there all day. Not every job is like that. And I think about where people of color work. I couldn't imagine if I worked at the supermarket, I would have that flexibility in order to engage in the clinical trial. All of that happened. I was on DARA for about a year, realized that it wasn't really making much progress. So we decided that I would not continue on DARA, but I was doing well. The myeloma it hadn't moved. We were good. I'm stable. We are in a pandemic in 2020. And I am home. There's all this hysteria about the pandemic. And one day, I was very sick. I could not figure out what it was. I saw my primary care physician. She thought I had a stomach bug. They thought I also had COVID. So I'd been tested like 20 times for COVID, all in a short period of time. The third time I went to my doctor, said, listen, something is wrong with me. And again, that patient advocacy that Amy talked about is so important. I said, Dr. Gu, something is wrong with me. I am not well. I'm not getting better. My stomach hurts. I have this low-grade fever. And finally, she ran all the tests she could think of, and it came back. I had renal failure at 38 years old. No high blood pressure, no other thing. Multiple myeloma. I had a CRAB symptom of multiple myeloma. So I had moved from MGUS, smoldering myeloma, to this aggressive multiple myeloma stage where I had renal failure. I was hospitalized for about 3 weeks and started dialysis, a short kind of dialysis and chemotherapy in the hospital during COVID, I might add. So there's no visits in the hospital. No one's coming. My daughter's birthday is on FaceTime for her 10th birthday. And during the pandemic, going to the hospital, I had to really employ family members. Like my dad had to bring me to Manhattan. And those are barriers to care. Because I imagine that a cab, I remember one day I didn't have a ride. It cost me $70 from Brooklyn, New York to the Coke Center, right? Imagine $140 for someone. That's a financial burden. But my dad took me back and forth, or I can get someone else. My mom sat outside sometimes of the Brooklyn Infusion Center while I received therapy. And so those things really made a difference. When I was stable enough, I went through a stem cell transplant. And Dr. Corday, Dr. Squirter, and I had a real conversation of what was important to me. My daughter was turning 16. I did not want to miss her 16th birthday. I also did not want that to be the cloud over my daughter's 16th birthday. Dr. Corday was like, please do not get COVID. Please stay masked. Please keep your hands sanitized. She knew it was important to me because my children are just super important to me. We were able to do the stem cell transplant immediately after my daughter's birthday. That was very difficult. You lose all your hair. You're in the hospital for about 3 to 4 weeks. You are home without a soul, just you, because you're in a bubble for about 100 days to lessen the chances of infection. So this is COVID, so I cannot have anyone in the house, in addition to all the other things that could happen. The cold, people, I couldn't clean the house, so I had to have a housekeeper come in to clean, to minimize risk of infection to my lungs. I could not go outside without masks and gloves. And so it was very intense to make sure you had a lot of support to do that. And I could not eat outside food. So people who cooked had to have like a whole sanitary kitchen set up in order to even bring food for me to ensure that I did not get infected, because I would be back in the hospital and that would not be a good situation. What was important to me in this care has been conversations with Dr. Corday. She's very open and asks questions about like, what is important to you? How does this work with your lifestyle? You know, are you financially okay? And when we talk about the referrals, I think where doctors can do a better job with referrals is referring to a person. As a social worker, I find that when you just like, well, call this number, people don't do it. At Kettering, they will call you. They will call you a million times. The nurse practitioner will call you to ensure that you have done whatever it is, the doctor's appointment, you know, a screening for this, a blood test, the flexibility about locations where I went to receive treatment. So that summer during COVID, when I had the renal failure and started chemotherapy, it was a 3-drug cocktail. Was not easy. I was able to choose coming to the Brooklyn location instead of going all the way into Manhattan, which was important, right? In order to make sure I had a drive, someone who could wait for me because I live in Brooklyn, as opposed to going to the Koch Center where everyone have to park in the parking lot and there was no place for people to sit because the access to the hospital was restricted during COVID. So those are kind of the important things that happened to me during my journey with multiple myeloma.
Thank you so much, Ms. Sylvester. That is a journey. That's a good word. It is a journey, but it sounds like. And can you tell me just in terms of the time frame for you? Like, was this like a year long? What was 2 years long? I might have missed it. I apologize.
I got diagnosed with MGUS smoldering myeloma in 2014, and it didn't progress until 2020. Literally, April or May 2020, I was in the hospital with renal failure.
Oh my gosh. So where are you today? Where are you today?
Today, I am in remission. As you know, multiple myeloma is not curable, but treatable. So I take 1 pill every day for 21 days. Even that is difficult, right? The pills are not great. Sometimes you have some side effects, and I am grateful I can call and say, this is not working. I have these stomach issues, or like, I just feel so nauseous. And we work to provide other medication to help with the side effects. So yes, I'm very excited to be in remission.
Well, yeah, I mean, that's the great word, the big R. I mean, it's fantastic. And to just 1 pill. Yes, I know it might be a big pill, but 1 pill is always good. I mean,
I was bald, like I had no hair. If I think about a year ago, I was completely bald. I think we had just said I was in remission a year ago this time. So
it was in the spring.
Yeah. So
wow, that is fantastic. All right, we have one more speaker, but I want to say we're going to try to take another 1 or 2 questions after we have Andrea speak. But if we don't, definitely, you know, you have the coalition support and continued prayers and support for your continued remission. That's what we're gonna claim it. Continued remission for Ms. Sylvester. All right, Andrea, can we have you Load your presentation up and talk about these important resources from
Yeah,
LLS.
thank you. Can you see my screen?
We can.
Awesome. All right. Thanks so much for having me here. I'm thrilled to be here. What a great program we are having. As they've said, my name is Andrea Nagle. I'm one of the patient and community outreach managers for the Metro New York region of the Leukemia and Lymphoma Society. Try to say that 5 times fast. I work alongside my colleague Jennifer, who is shown here on the slide, and we have colleagues around the country. Locally, I have my colleagues here who work in the New Jersey territory and the Connecticut Hudson Valley regions, Stacy and Melissa. And so if you have your phone out and you want to take a screenshot so you know who your local patient community outreach manager is, please feel free. Our role is to connect patients and caregivers with LLS as soon as possible after a blood cancer diagnosis. And I want to say we want to reach everyone, all blood cancer patients, regardless of income, race, ethnicity, socioeconomic status, or location within the region. I want to share more about our organization in case you're not aware. We are the largest nonprofit specifically dedicated to addressing issues of blood cancer. Our mission here is on the slide, which is to cure leukemia, lymphoma, Hodgkin's disease, and myeloma, and improve the quality of life for patients and their families. And so you can see here, we do this in 3 ways. We do it through research, we do it through advocacy, and we do it through education and support. And that last pillar is where my work is focused and what we'll talk about today. First and foremost, I want to highlight our Information Resource Center. If you remember nothing else from what I say, I hope you remember this phone number. If you call us, you will speak one-on-one with one of our team of master level oncology nurses and social workers. They can sit with you on the phone and assist you through questions about your cancer treatment, your financial and social challenges, COVID questions, and give accurate, up-to-date disease treatment and support information. As you can see on the slide, we also can connect you to one of our free personalized nutrition consultations or to our clinical trial support center. We've talked a lot about clinical trials and some of the barriers to participating in clinical trials. We've also talked about the need for clinical trials to include a wide variety of people so that we can get the best care and treatment options that work for everyone. And so our clinical trial support center, I want to highlight here, this is a free service. You will meet virtually with one of our nurses in the clinical trial support center. They can talk you through finding a trial that's appropriate and match you with that trial. So as Amy had said, sometimes there's a discussion of trials, but the link is never made. These nurses will help that link to be made. And so that's really critical. And if you call our Information Resource Center, they can connect you. Once you connect with us, you have access to countless resources. I do not have time to go through them all, but I want to just point out that we do have emotional support resources, educational support resources, and financial support resources. I am going to take just half a minute to go through the second two categories. But first, just for emotional support, I want to mention we do even have a peer-to-peer support program where we try to match you with someone who has had the same or a similar experience with you, whether you're the patient or a caregiver. For education and financial support, we'll talk through that now. So for financial support, this is a very busy slide, but just notice the part in yellow. I'll go through very quickly some of our financial support resources, and just know that you will get these slides and you can see here the website and the phone number you can call for more information. Patient aid is a $100 one-time stipend. It's given to all cancer patients who apply, and it's regardless of citizenship. So while the other programs here do require proof of citizenship, this patient aid does not, as do many of our other programs. They also do not require citizenship. The copay program, I just want to point out here that you hear copay or insurance premiums and you think, oh, wow, that's great. Well, I want to tell you even better news that we've expanded this to include costs that are associated with labs, scans, medications, x-rays, et cetera, et cetera, et cetera. We've also added an instant decision component. So if you call, you get a decision right there on the phone and you have access to those funds immediately. We also have programs that are for non-medical costs like rent, utilities, childcare, transportation, et cetera. One of the things I highlighted on this slide in yellow is that our Myeloma Fund happens to be open right now. And this is a stipend of $500 to be used towards transportation and lodging costs associated with treatment. And you can apply every 6 months. More information is on our website, but I want to point that out because our funds do open and close. So they are dependent upon the availability of funding. So if you go on our website 1 week and you say, Andrea, your copay for myeloma wasn't open, just check the following week or the following month and it can be reopened. So don't get discouraged, please continue to check. And then my last few slides here, for the sake of time, I'll go a little bit quickly. Just know you can always reach out and we can talk more. For education, we have such a wide variety of reliable information. I would hate to see a patient go down the Google rabbit hole when you can get reliable information downloaded for free from our website or sent directly to your home. You can order it just like you would on Amazon and it will be delivered to your home. We have booklets, we have information sheets, we have a brand new survivorship workbook that can help you track your treatment, track what you need to do, and then when your treatment's over, what now? So we have just an amazing array of resources, and those include things related specifically to myeloma. I want to note also, you see on the slide, we do national and local programs. This is an example of a local program, which my colleague and I also do probably monthly at this point. And we also have webinars, videos, blog posts, a podcast for patients that feature other patients or caregivers talking with cancer experts. And then again, our fact sheets and workbooks. And then for those of you who are on the call that happen to be healthcare providers, I just want to let you know that we have things for you too. We have free CE and CME programs. We have a podcast also for you discussing the latest treatments in the blood cancer arena. And then we also have a Staying Connected program, which is for teachers, school nurses, social workers, et cetera, who are focused on the needs of a child or adolescent or young adult returning to school after treatment. And so as a reminder, because there's been so much information shared, if you remember nothing else, again, this is our phone number. If you're a professional, please use our referral form online to get your patients referred to us, and we will call them within 48 hours. And if you're a patient or caregiver, please don't hesitate to call this phone number. We are here for you. You are not alone. And once you join us, you are part of a community that is with you throughout the journey. It's not a one-time phone call. You'll be connected to our volunteers and to our community of survivors in the area. And that's it. So thanks so much for listening. I hope you'll consider reaching out to us if you need to. And I look forward to the rest of the presentation.
Thank you, Andrea, for that fantastic information, and thank you for keeping us on time too. We know that you're a pro at this. You know, you're doing it almost every week, so fantastic. You know, I think the last thing you said, you used the word community, Andrea, and I think that that's really what this is all about. That we are not an island. We're not out here all on our own. There are providers who care, right? There are people doing the research, the data collection, as Amy described. There are other patients willing to support each other. You have LLS that's willing to just sort of pull everybody together. So there is support. And you have folks like the Coalition of 100 Black Women who are really trying to do good work in bringing everyone together as well, just for information. So I do have time. Maybe you can take one question, one burning question, if anyone has one, from Andrea or Miss Sylvester. I don't think there's anything. Otherwise, I can turn it over to my colleague, Adina. Oh, Danielle George, did you have a question, Danielle?
Yeah, hi. I have a
Hi.
question for for Nadine, and it's basically you described how you had apprehension about joining the clinical trial at first, but then throughout time you were able to change your decision. And I just want to know, what steps did you take, or what necessarily swayed you from being apprehensive and kind of like, no, I don't want to do a clinical trial, to being more proactive about it?
Research. So I'm a trained social worker. I am not a clinician. I mean, I am trained clinician as a clinician. However, I'm a researcher and administrator. So I started to look at other researches that really changed the needle. So a long time ago, I used to work at SUNY Downstate in the STAR clinic, which was specifically for people who are infected with HIV or AIDS. And I'd seen the change when I first started working there. People were taking 13 to 26 pills per day to now 2 or 3 pills. And that was because of clinical trials, right? In the hospitals, in the rooms, we've seen the change, and that people with HIV it's not a death sentence anymore. People with HIV, AIDS, it's not a death sentence. And so I was like, let me try this, right? It's better to have tried than not to extend my life for my children.
Awesome.
And I asked Dr. Corday lots of questions. Like, what about this? And what about that? What would happen if this happened?
But we got through it, and you're a brave, brave warrior. You're amazing.
Thank you.
I love that. I love that. I love that. All right. Adina, why don't I hand it over to you for the close?
Yes, thank you. Thank you to our panelists, our speakers, the wonderful information that was shared. And as Rita Peterson just put in the chat, you know, the information shared is priceless, and our experience as well. So we want to thank everyone that attended this training, this presentation, this webinar from the National Coalition of 100 Black Women. We always want to let everyone know that we have a lot of information on our website, especially when it comes to upcoming events. We have, you know, this is the month of women, you know, March is Women's Month, and we have a lot of events coming up. On the 17th is our next event, Sex, Power, Policy, and Politics, the Compelling Circumstances of Leadership, which is our immediate next event. So please, there's a link there to our events page. We'll also put the link for our donations page. Without you, without your support, you know, we need to have more of these programs, so we need some donations, and that is the direct link that you see here to click on, and you know, $5 goes a long way. So anyway, thank you all. Have a wonderful night, and thank you again, panelists and our wonderful speakers, and have a great month.
Just one more thing. Please don't go yet. Please. I think Deshawn is still on. We do have a poll, a survey that was a poll that I'd love to launch. So unfortunately, I can't seem to launch it. So I don't know if it was here before. I'm sorry. I don't know, Deshawn, if you're on. Can you launch it? I think you might be co-host. If not, that is okay. That's okay. I don't think we can launch. All right. I would say it was an outstanding program. I give all 5s. Absolutely excellent. Thank you all. Thanks, Adina, for closing us out. And have a good evening, everyone.
Good night, all. Good evening. Good night.